91%. That is the survival rate when colon cancer is caught early. But here is the number nobody talks about: 14%. That is what survival looks like when it is caught late. Same cancer, same body, same treatments. A difference of 77 percentage points determined by one thing alone: how early someone paid attention. And right now, somewhere in America, a senior is explaining away the exact sign that could make the difference between those two numbers. Calling it stress, calling it age, calling it nothing, while the window slowly closes. Welcome to Senior Logic. Today we are covering 10 signs of colon cancer that seniors most commonly miss. Not just the obvious ones, but the ones that appear in the urinary tract, in the back, in the legs, in places that virtually no senior and sometimes no physician would spontaneously connect to the colon. According to a PMC study on colorectal cancer symptomatology, urinary symptoms were present in 4.5% of colorectal cancer patients at diagnosis, back pain in 7.3%, pelvic pressure in 2.1%. These are signs appearing in systems completely outside the bowel, signs that miss their diagnostic window because no physician thought to ask and no patient thought to report. This video is for educational purposes only. These signs have many causes other than colon cancer, but any sign that persists beyond 2 weeks without a clear explanation should prompt physician evaluation. Stay until sign number 4, because that is the sign sending the most seniors to the wrong specialist while the real problem continues to grow. Sign number 10. Persistent fatigue with pale or yellowish skin. Not the tiredness of a long day, not the fatigue of poor sleep. This is a tiredness that does not respond to rest. You sleep 8 hours. You wake up exhausted. You sit down to recover. The exhaustion stays, and alongside it, something is changing in the mirror. The skin looks more washed out, more pale, more sallow than it used to be, and in some cases a faint yellowish tint has appeared in the skin or around the eyes that family members noticed before you did yourself. Here is the biology behind what you are seeing. A colorectal tumor can bleed, not in a dramatic or visible way. Just a slow, silent, invisible leak, too small in volume to produce visible blood in the stool, but large enough to progressively drain the body's iron reserves over weeks and months. As iron falls, hemoglobin falls with it. Hemoglobin is the compound that gives blood its red color and gives healthy skin its warm rosy undertone. When hemoglobin drops below normal, the skin loses that undertone entirely. It becomes the pale, washed-out appearance of iron deficiency anemia. According to the American Cancer Society, sometimes the very first sign of colorectal cancer is a blood test showing a low red blood cell count. The yellowing tint jaundice appears in more advanced disease, when cancer has reached the liver and the liver's ability to process bilirubin becomes impaired. There is a practical 10-second screen for this that any family member can perform right now. Gently pull down the lower eyelid of your elderly relative. The small strip of tissue on the inside of that lid should be pink, healthy red pink. If it appears pale, almost white, compared to your own inner eyelid in natural light, that is the hemoglobin deficit made visible. That is anemia you can see with your own eyes. A complete blood count and liver function tests should be explicitly requested at the next physician appointment, not eventually, at the next one. Sign number 9. Unexplained weight loss of 5% or more of body weight over 6 months. Weight that is dropping without a dietary change, without new exercise, without a clear medical explanation. Weight that friends and family are noticing in the face, in the clothing, in the way a person carries themselves, before the person has fully noticed it themselves. According to the American Cancer Society, unexplained weight loss of 10 pounds or more is a specific and documented colon cancer warning sign. According to MD Anderson Cancer Center, constitutional symptoms including weight loss are among the colon cancer presentations that prompt clinical investigation. The mechanism is not simple. A colorectal tumor generates pro-inflammatory compounds that suppress appetite signals at the level of the brain. The physical narrowing of the colon alters how nutrients are absorbed and how waste moves through. And the chronic blood and protein losses from the tumor surface deplete the body's nutritional reserves continuously faster than any ordinary dietary reduction would explain. This is not the natural weight shift of aging. This is the body being systematically depleted. A senior who has lost perceptible weight in recent months without trying, whose clothing fits differently, whose face looks thinner to family members, alongside any digestive or constitutional sign from this list, warrants a physician evaluation that includes a complete blood count, a metabolic panel, and explicit consideration of colorectal cancer investigation. Sign number 8. Changes in bowel habits that persist beyond 2 weeks. A new pattern of constipation, a new onset of loose stools, or a cycling between the two that has replaced a previously stable and predictable bowel routine. According to the PMC study on colorectal cancer symptoms in elderly patients, change in bowel habits was one of the 4 most frequently reported presenting symptoms in elderly colorectal cancer patients. The distinction that separates a colorectal cancer bowel change from the common bowel irregularity of aging is specific and important. A bowel change caused by a new food, a new medication, or or a brief digestive illness corrects within days when the cause is removed. A bowel change caused by a growing tumor within the colon does not resolve with dietary fiber. It does not respond to probiotics. It does not respond to laxatives. It persists, and it may worsen progressively as the tumor enlarges and the narrowing of the colon becomes more pronounced. According to MD Anderson Cancer Center, patients describe an odd sensation of fullness in the abdomen and changes in bowel habits as among the most common presenting experiences. Right-sided colon tumors typically produce diarrhea. Left-sided tumors typically produce constipation. An alternating pattern, several days of constipation followed by loose stool, can reflect the bowel's attempt to clear material past a partial obstruction that the tumor is steadily creating. A bowel change that has lasted more than 2 weeks without a clearly benign explanation deserves physician evaluation, and stool testing is the minimum first step. Sign number 7. Leg swelling and foot pain without a cardiac explanation. Bilateral or unilateral swelling of the lower legs and feet that has developed without a cardiac, venous, or kidney explanation. Or a deep aching or burning in the feet and lower legs that resembles circulatory insufficiency, but whose cardiac workup has come back essentially normal. A tumor in the sigmoid colon or rectum can compress pelvic veins and lymphatics as it enlarges, obstructing venous and lymphatic return from the lower extremities and producing leg swelling through physical obstruction rather than cardiac failure. And there is a second mechanism that is even less recognized. Advanced colorectal cancer can produce a hypercoagulable state through tumor-derived procoagulant factors, predisposing to deep vein thrombosis in the leg veins, an unprovoked blood clot in the leg, appearing without surgery, without prolonged immobilization, without long-haul travel, can be the presenting sign of an occult malignancy that has not yet produced any bowel symptoms at all. Any unilateral leg swelling in a senior without a prior diagnosis of deep vein thrombosis or heart failure, particularly when accompanied by any digestive or constitutional symptom from this list, should prompt investigation that includes colorectal cancer in the differential. Sign number 6. Persistent abdominal cramping, pressure, or bloating. A discomfort in the mid or lower abdomen that is present most days. That has progressively worsened over weeks to months, and that does not fully resolve with dietary changes or over-the-counter remedies. According to MD Anderson Cancer Center, most patients who present with pain describe an intermittent crampy feeling in the abdomen, and an odd sensation of fullness is one of the more common presenting experiences. The cramping and pressure of colorectal cancer reflect the tumor's mechanical effects on the bowel, the partial obstruction of stool passage, the local inflammatory reaction at the tumor site, and in advanced cases, the tumor's extension through the bowel wall into surrounding tissue. A senior who has been quietly modifying their diet for months to manage persistent abdominal discomfort, avoiding certain foods, eating smaller portions, keeping antacids nearby, without having reported this pattern to a physician, has not received the evaluation their symptom warrants. Persistent abdominal cramping present for more than 2 to 3 weeks without a clearly benign explanation deserves physician evaluation and stool testing as a minimum first response. Sign number 5. Lower back pain that wakes you at 3 in the morning. Back pain that does not respond to physical therapy. That appeared without a new musculoskeletal injury. That is present specifically at night and in the early morning hours. And that is accompanied by any digestive or constitutional symptom from this list. The back pain that can occur with colon cancer does not behave like mechanical back pain. It does not worsen with specific movements or positions the way disc disease does. It may persist even after physical therapy and pain management. And critically, it is worse at night and in the early morning when the body is at rest and the anti-inflammatory effect of daytime activity has worn off. It may specifically wake the person from sleep. A senior who describes their back pain is worst at 3 or 4 in the morning, waking them from sleep, while their daytime pain is more manageable, is describing the nocturnal inflammatory pattern that distinguishes visceral or bony cancer pain from mechanical musculoskeletal pain. This timing pattern, combined with any gastrointestinal symptom, warrants investigation that goes beyond physical therapy and lumbar spine imaging to include the gastrointestinal system explicitly. Sign number 4. Urinary symptoms with no urological explanation. New onset of urinary urgency, increased frequency, difficulty initiating urination, or a persistent sensation of bladder pressure that has appeared without a urinary tract infection, without a new prostate diagnosis, and without a structural or neurological explanation. According to the PMC study on colorectal cancer symptomatology, urinary symptoms were present in 4.5% of colorectal cancer patients at presentation, a proportion small enough to be clinically overlooked, but large enough to represent hundreds of thousands of unrecognized presentations annually. The anatomical mechanism is direct. The sigmoid colon lies immediately adjacent to the bladder. The rectum lies posterior to the prostate in men and posterior to the cervix and vagina in women. A tumor in the sigmoid colon or upper rectum that grows beyond the bowel wall can press against the bladder, producing urgency, frequency, and pressure that the patient and every specialist attribute entirely to the bladder or prostate. In the most advanced presentations, the tumor erodes through the bowel wall into the bladder, creating a fistula through which stool enters the urinary tract, producing recurrent urinary infections that never fully clear with antibiotics. Any senior with new urinary symptoms who also has any digestive symptom from this list should use these specific words with their physician. Both of these symptoms started around the same time. That concurrent onset, two different body systems changing within the same time window, is the clinical signal that transforms two apparently separate problems into one investigation examining the anatomical relationship between the colon and the structures it neighbors. Sign number 3. Rectal bleeding or dark tarry stool. Bright red blood on toilet paper or in the toilet bowl. Blood mixed into the stool producing a darker, more uniform discoloration throughout, not just coating the surface. Or stool that has become black and tarry, indicating blood from higher in the digestive tract. According to the American Cancer Society, colorectal tumors often bleed into the digestive tract, and rectal bleeding is among the most specific single symptoms for colorectal cancer risk. The danger in the senior population is the hemorrhoid attribution. The majority of seniors have hemorrhoids, and when blood appears after a bowel movement, the explanation is ready before any investigation has occurred. But hemorrhoidal blood sits on the surface of the stool, bright red, coating the outside. Blood from a colon tumor gets incorporated into the stool itself. Darker, mixed throughout, not just on the surface. Any blood mixed into the stool rather than coating it, regardless of known hemorrhoids, requires physician evaluation. The hemorrhoid does not rule out the cancer. Both can exist simultaneously. Assuming one explains the other is one of the most consistently dangerous mistakes in senior health. Sign number 2. Swelling or firmness in the groin or pelvis. A palpable lump in the inguinal area. A sense of heaviness or fullness in the lower pelvis. Or a firmness in the lower abdominal or groin region that was not previously present. Colorectal cancer can spread to the lymph nodes of the pelvic and inguinal region. A node that is larger than 1 centimeter, hard rather than soft, and fixed in position rather than freely mobile, that has appeared and grown over recent weeks warrants imaging. According to documented PMC case reports, rectal cancer can present with inguinal lymphadenopathy that is initially misattributed to hernia, infection, or benign causes. A senior who notices new firmness or fullness in the groin or lower pelvis, particularly alongside any digestive or urinary symptom from this list, should request abdominal and pelvic imaging as part of the evaluation rather than assuming the finding is musculoskeletal or benign. And sign number 1. Acute bowel obstruction. A surgical emergency. Sudden and severe abdominal pain. Abdominal distension that has appeared rapidly over hours to days. Complete inability to pass stool or gas for more than 24 hours. Nausea and vomiting. A visible distension of the abdomen that is hard to the touch. According to NCBI StatPearls, colorectal cancer is among the most common causes of large bowel obstruction in adults, and acute obstruction as a presenting feature of colorectal cancer occurs in 8 to 29% of cases. As a tumor progressively narrows the colonic lumen, the colon proximal to the obstruction dilates from accumulating material it cannot expel. The pressure within the bowel wall rises. Perforation risk rises with it. This is not a symptom to monitor at home. This is not a sign to bring to a scheduled appointment next week. Any senior presenting with sudden severe abdominal pain, complete cessation of bowel function, and visible abdominal distension requires emergency evaluation without delay. Colorectal cancer screening remains the most powerful tool available for preventing every symptom on this list from ever developing. Colonoscopy, performed at the recommended intervals, every 10 years from age 45 for average-risk adults, identifies and removes the precancerous polyps that develop over a 5 to 10 year period before becoming invasive cancer. The senior who has the colonoscopy never needs to recognize the signs, because the polyp is removed before it becomes the cancer that produces them. For seniors with concerns about colonoscopy, the fecal immunochemical test, the FIT test, offers an annual non-invasive home alternative that detects occult blood in the stool. A positive FIT leads to the colonoscopy that provides definitive evaluation and treatment. The screening conversation with a primary care physician is the most important action any senior over 45 can take for their colorectal cancer risk. And it should happen at the next scheduled appointment if it has not already. 91% survival. That number is real. It is achievable. But it belongs only to the people who act while the window is still open. The window is open right now.